So first introduction. So I'm John Ainsworth. I'm Professor of Health Informatics here at the University of Manchester. And so that's my main job, right? So that's quite a busy job. I'm also head of division, so I do that as well. So obviously all the normal academic things. But from my division, which is the Division of Informatics, Imaging and Data Science, one of the things we are very focused on is actually impact for our research. And so actually translating our research into practice. And we've done this multiple times across a range of different technologies. So what I'm going to talk to you today about is one instance of this, which is CareLoop Health. So I'm also a founder and inventor of the technologies that exist inside CareLoop Health, which is essentially a remote monitoring system for people with schizophrenia that enables you to actually target care to where it's needed. So I'll get into that a little bit as well. CareLoop Health itself was actually founded in February 2021, and we are just hopefully about to close our seed investment. So that's the first stage of venture capital invested into the business. A little bit about the domain that we're in. So this is a typical time series of relapse in schizophrenia. So schizophrenia is a lifelong condition characterized by frequent relapse into psychosis. And what we know about this is a disease that if you're able to identify early warning signs of a relapse into psychosis, you can actually intervene and change either the severity of that relapse or indeed stop it happening entirely. And so this insight is where we started from our research, and is what we've actually managed to do and demonstrate that we can do, and I'll show you how we do that in a second. So this slide might worry some people in that it starts in 2008 and it's 2024. So 2008 was when we had the first idea that we might want to do this, right? That we could actually use the technology to monitor symptoms of people and use algorithms to detect early warning signs of relapse into psychosis. I have this slide from about 2010. So when we put our first grant into the MRC, which will have been around about 2009, saying we want to use technology to monitor symptoms in real time from patients, this is what we said, and I don't know if anyone in the audience is old enough to remember what one of those things is, but it's a palm, it's palm tungsten, isn't it? Palm tungsten PDA. So this was before the advent of smartphones. And in fact, by the time we'd actually put the grant in and actually got it funded, maybe 18 months, 12 months, these things were discontinued and obsolete because actually smartphones had completely taken over. So there's a lesson here in that actually technology actually moves very fast. And if you're trying to use technology, the pace of evidence collection and grant funding moves very slowly, and there's a complete mismatch between these two things. So that's one thing that you have to try and bridge. But anyway, that's a message. So this is what we ended up doing, essentially. We have a smartphone. It basically asks patients to self-report their symptoms. So it's just a simple questionnaire, but the questionnaire is validated against clinician gold standards. So we know we're getting reliable symptom data. That goes onto a server, it's presented to clinicians that they want to see it. There's an algorithm that runs on the server that can detect from the self-report symptom whether someone is showing those early warning signs of relapse into psychosis. Then you can alert the care team and they can actually go and visit that person and do the intervention, and that prevents a relapse. We also do a bit of cognitive behavioural therapy delivery as well to help people manage their symptoms as well. So this is what it is in essence. But it took us from the first idea, 2008, through the first trial, which was funded in 2010, where we validated the self-reporting via smartphone. We did an RCT in between, which first looked at, can we do algorithmic detection of early warning signs? In that trial, we didn't, because our algorithm was very naive. But then we moved on, did some CBT stuff in between, and then by 2022, we concluded the third trial, which was Empower, where we actually showed that we could do this. And we actually showed it quite well as well. So this is the summary of the results published in the Lancet Psychiatry 2022. And we demonstrated, excuse me, that we could cut relapse by 50%. So that's a massive number, right? The field of psychiatry has not seen anything like that in schizophrenia. In fact, there's been no treatment innovation for about 40 years. No new pharmacological treatments. So this kind of is a bit of a game changer, really. And we lengthened the time to first relapse. People became less fearful of relapse, and it's actually potentially a feedback mechanism there. The less fearful of relapse you are, the less relapses you'll have. Reduced hospital admissions, had great adherence to the app, did the health economics study, and ended up with an incremental cost effectiveness ratio of about 3,000, which is also really, really good, right? So research, all done, right? Clearly demonstrated evidence of efficacy, efficiency, safety, everything else. So we're ready for blast off, right? We can really get this thing moving, get it off the ground, and off we go, because we've done all the research, we've got all the evidence. This should be easy, right? But actually, there are a number of different considerations here that actually, if we'd thought about these a bit earlier, it would have made things a lot easier. And these are, what is the business you take it forward? How do you protect your IP? What people are going to take it forwards? Actually, what is your product? And can you demonstrate that you can sell that product into, say, the NHS? And how are you going to fund that thing? And my message today is actually we need to start thinking about these things really early to enable us to do translation effectively. And I'll run through what we did. And if you don't think about them, you end up potentially with the rocket falling back down to earth, right? And I think that's the message. So, business. What kind of business is it going to be? So naively, we first thought, well, let's create a social enterprise and not for profit, because actually all we want to do is get this out into the NHS, make it work. We actually tried that, didn't work. And part of the reason why it won't work, in our case, is we needed investment to develop the product, to go and sell it. And you can't get investment into a non-profit, or you can, but it's very, very difficult. So we scratched that off and we created CareLoop Health, which is a limited company and has shareholders, and was created partly through investment with the university, which is also a shareholder, because it spins out their technology. Then the second thing we need to think about was kind of our business model. So in our case, we've got some technology that's an app. And when people look at it, they go, oh, are you going to sell that directly to patients? Or are you going to sell it into the NHS? In our case, the world is full of apps that litter the App Store that are direct to consumer, that purport to manage your mental health, for example, but have very little evidence. And so we decided that actually, where our space is, we're actually in a regulated space. We're a medical device. And we sell this technology to the NHS, and doctors then prescribe it to their patients. And that's the model that we wanted to have. Then the next one was understanding markets and customers as well. So you need to have quite a clear understanding of who's actually going to pay for this thing, who's actually going to buy it. And indeed, if you talk to investors, they're quite skeptical sometimes that you'll be able to sell this into the NHS directly, because the NHS is quite strapped for cash at the moment, right? So being realistic is, has the NHS got the capacity to take this on? Has the NHS got the capacity to embed this and change pathways in a restricted budget environment? So you also need to think, well, are there different markets across the world where this will fit better? So, for example, it's forced us to think, well, actually, we really need to enter the US market. We can prove it in the NHS, but actually we need to enter the US market. So that's business. Intellectual property. I think, Harriet, you mentioned open source before, which is one way of managing your intellectual property. But often we're faced with the question of whether we want to actually patent our technology or not patent it. So this actually probably doesn't apply particularly if you have a software product, because software is not patentable, algorithms are not patentable. If you have a new molecule, for example, that's definitely patentable, and that's probably the route you would take. And so typically with a software business, you won't be doing this, and definitely not if you open source it. But however, in our case, actually, what we've got is essentially an algorithm. The details of how it works are intellectual property. And so we keep that basically as a trade secret, and that's the way we protect our IP. You need to be very careful what you publish as well. So if you do want to patent something or obviously keep it as a trade secret, there's this tension, I think, between academics wanting to publish, needing to publish, but also protecting your intellectual property so that you can then spin it out later. And then finally on IP, how will it work with the university? Will they be assigning this intellectual property into the business, or will the model be one of licensing, whereby actually you're paying every time a royalty payment, every time you make a sale, pretty much. And different universities take different positions. There was an interesting report that came out a few months ago about looking at the model that universities have for their spinouts and suggesting that actually most universities had the model wrong and needed to change, which is very helpful for innovators like us. Then the other consideration in terms of intellectual property is funder considerations. So depending on who's funded your research, they will take a different position regards whether they want to get a cut out of it or whether they funded it in the public good and it's done and that's it. So for example, National Institute of Health Research, they'll want to see something coming back. Charities will often want to see something coming back. UKRI, less so. So it all depends on who's funded it. Then people. So here are my wonderful colleagues. So that's Professor Sharon Lewis, Professor of Adult Psychiatry at the top left, Professor Sandra Bucci, Clinical Psychology, bottom left, and Pauline Whelan, our technology lead. So these are the four people who've essentially been with the business all the time and have done the research and have led it. However, the key point here, I think, actually is academics don't particularly make the best entrepreneurs, right? We don't have the skill set because we don't really do sales, we don't really do marketing, we don't really do finance. So what we did, we were very lucky, we managed to find ourselves an experienced CEO who'd worked previously in a digital mental health business, had many experiences, had grown that business from 1 million to 10 million. And she agreed to become our CEO. And this is Zoe Blake, and I'm very pleased to say she's driving the business forwards. But I think here the key lesson is make sure that you have the right people in the business that can actually drive a business forwards. And then next one, product. So what we've done with our algorithm, we've essentially created software as a medical device, and it is actually regulated as a Class 1 medical device by the MHRA. This has all sorts of implications, not just for how you place it onto the market, but also how you've designed it and how you've developed it, because you are required to demonstrate that you've actually done this in a structured, repeatable, documented way. And one of the key things that drives this is something called the ISO 13845, or was it 13485? I know, I can never remember. Quality management system, which really sets out a framework for how you're supposed to develop software as a medical device and the processes you need to follow and the documentation. And as a business or as an organization, you can become certified as ISO 13485, which demonstrates that, yes, you have the processes, and yes, they are repeatable, and yes, you are reliable to manufacture software as a medical device and place it onto the market. So there's that as well. Another thing we've also managed to do is we've managed to go through something called the NICE Early Value Assessment. So it's quite interesting. NICE have recognised that there was a lot of software tools, digital tools that potentially could provide benefit, but have not been through the same level of evidence collection as you might see for, say, a pharmaceutical product. And so they developed something called the Early Value Assessment, whereby the basic premise of it is if you have promising evidence that you can go through early value assessment, NICE will approve you for use in the NHS, provided you then collect what they call real-world evidence and data. And this is exactly where we are as well. So we've just been through a NICE early value assessment, and we're now collecting real-world evidence. Then when it comes to actually selling into the NHS, there are a whole load of other things that you need to consider that you probably wouldn't think of before you actually tried to do this. So there's something called the DTAC, and I can never remember what the acronym stands for. Probably something like Digital Technology Assessment Criteria, thank you very much, which essentially is a pro forma that you have to fill out to demonstrate that actually the way you develop your digital health software, it conforms to various different standards for privacy, confidentiality, cyber security. Similarly, you'll probably need to register for the NHS Digital Services Privacy Toolkit, maybe right about. Thank you. Again, this is another standard that the NHS requires you to fill in to demonstrate as an organisation that you are compliant with various cybersecurity policies, information management policies. And then also Cyber Essentials, which is more of the same, but is more of a generic. This is how we manage cybersecurity as an organisation. And then the curiously titled DCB 129. And the DCB 129 is all about clinical safety and clinical risk management. And don't ask me what DCB stands for, because I cannot remember. But the DCB is a process that you as a supplier of digital health tools have to go through. And again, it's another pro forma. But then there is a corresponding DCB, I think it's 160, that an NHS organisation that you're selling to and they're adopting will have to fill out to correspond to your tools. So actually, I suppose that the key message here is once you get through academia and you think you've got a product, well, you haven't really got a product, because until you do all of these things, particularly if it's a medical device, and not everything is a medical device, but anything that touches on patient data and modifies data to any kind of degree is likely to be a medical device, then you're going to have to go through these things. And the important point about these things is they're not trivial either, right? So to establish a quality management system whereby you can be certified to the ISO standard is not a trivial undertaking. developing your software and having a paper trail of starting from when you very first designed it all the way through to how did you verify and validate it is not a trivial undertaking. And neither is the DTAC or the DSPT Toolkit, Cyber Essentials, or the DCB, right? So what you see here, essentially, is a whole load of work that you have to do and you have to finance some way before you can actually translate your digital health tool that you've done in academia into practice. So where do you get the money from? So financing. So I mentioned before about using the approach of a not-for-profit social enterprise. And the real reason why we couldn't make it work is because we had no money in the business to do all those things that were on the previous slide. So there's only two different ways you can really do this, I think. And it's either bootstrap, whereby you're actually somehow able to make sales, and that pays for you to do these things, or you seek investment. Now, bootstrap is very difficult for the reasons I just outlined on the previous slide, that you need to have quite a bit of investment before anybody in the NHS will even look at your product. So typically, you're going to be looking at investment. Now, there are different ways to get investment. What we've done in CareLoop Health is we've gone down the venture capital route. Potentially, you can survive on additional grants, so Innovate UK, for example, but that's quite difficult to achieve. So if you do down the venture capital route and you start talking to investors, what you find is there are different classes of these investors. And they look for different things. So they may be a biotech investor, they may be a software platform investor, they may be what they call a deep tech investor, so where you've applied some kind of AI and it's the very latest thing and it may not actually have a product, but hey, just look at the AI, isn't it great? Or they might be a health tech investor. And actually matching yourself to the right investor is really quite important if you don't want to waste your time having endless conversations and you're never going to fit. Some of them, such as the platform investors, they want you to be Facebook, right? And they want to show how you're going to have 2 billion users in the next 5 years, which clearly for many different tools is not going to happen. The other thing they're going to look for is growth. So it's not good enough to say, oh, well, we're going to conquer the NHS. They want to know how you're going to conquer the world. So where's your next market? Is it the US? Is it Europe? Is it Southeast Asia? And so you have to have a business plan that demonstrates how you're going to conquer these markets if you want to get venture capital investment. And that's not all. They also want to know how you're going to grow. So one product isn't enough, right? You have to have a pipeline of products that demonstrate you're going to grow and open up new markets as well. And so in our case, we do have another product, and that's going to be a bipolar product. So schizophrenia, bipolar, we're going through the severe mental illness spectrum. So if you want to get that kind of investment, you need to both. And then finally, any investor will also want to know, how do they get their money back, plus some more money? So where's the return on investment? How do you actually exit this business? Do you do an IPO, initial public offering, and become a publicly traded company? Or do you actually manage to sell it to somebody else? They want to know how you're going to do that as well. So I'm going to summarize lessons learned, and I picked, I think, the top ones. My first one would be, the sooner you think about this, even when you're thinking about developing that first tool, writing that first grant, if you can try and think about how you're going to do these things, right, it makes it a whole lot easier because you can plan for it. For example, if you're generating a medical device, then think about how you're going to structure the development of that and capture all the documentation you need. Understand your IP position. So what are you going to do? Are you going to open source it? Are you going to patent it? Are you going to keep it as a trade secret? and work with your technology transfer office in your university to help you understand what's the right way. Can't say this strong enough, and I hope I've made this point. Academic research does not equal market-ready products. There is a huge gap between these two things. People identify who will run and grow your business, right? Typically, in my experience, academics can do this. Some of them are okay at it, but by and large, they're not good at this. So can you find somebody who has the skills, knowledge, and experience to make this happen? And I think this is my final point. Understand who might be interested in investing in the business model that you want for this. So it might be an open source business model. It might be purely product-driven model. It might be you've got patentable technology that you want to license. But understand who will invest in it, why they want to invest in it, which is typically because they want to make more money. So how are they going to make that extra money? My final point, and not on the slide, but I think one of the things that you really need as an academic to do this is perseverance, right? This is not easy, but the rewards, I think, are very great, because actually being able to have the satisfaction of some research you've done actually being deployed and making a difference to people's lives is really what motivates me personally. And I think it's hard, yes, but there is such immense satisfaction from doing it, I would recommend you try. Thank you.